Good morning, everyone, to this early morning breakfast session. As Dr. Faisal has said, I'll be talking about indications and the general considerations for glaucoma implants in the management of glaucoma. So, what are these glaucoma drainage implants? We all know these are the devices which basically drain or divert the aqueous from the anterior chamber into an external reservoir, which is usually the subconjunctival space. Uh, the drainage doesn't start immediately. Obviously, it depends on the type of implant which we have, but basically the process starts with the formation of a fibrous capsule about 4 to 6 weeks after the surgery, which actually regulates the flow of aqueous from the anterior chamber to that external reservoir. So, where are these implants used normally in our practice as a glaucoma surgeon? It is basically mostly cases of previously failed trabeculectomies and those cases where there is a complicated look of the eye with scarred, extensively scarred conjunctiva and or insufficient conjunctiva for a trabeculectomy to be done. Or there are certain situations where complicated glaucomas or difficult cases of glaucomas where I would say they may be the first line of choice as a surgery. So all these glaucoma drainage implants have a basic design of having a tube and a plate, end plate, that with difference in sizes, difference in the material of the end plates, and they're basically classified as two types based on the presence or the absence of the valve which is there. And how do they operate? Basically, what is happening, this video is not playing. Anyway, so what is happening is basically what the aqueous humor is going through the silicon tube to a reservoir, which is outside the GDI plate, which is formed by the encapsulation occurring over a period of 4 to 6 weeks, I said. Aqueous humor from this space then goes into the actually gets absorbed into the lymphatic vessels and the tenons, passing through the tenons and the conjunctiva, which has the part of that fibrotic capsule, which has formed around the end plate and is absorbed from the capillaries out there. So with the advancements, there have been in the development of these glaucoma drainage implants, there have been now with these drainage surgery, we're able to achieve greater success, lower complication rate, and we are able to facilitate implantation in an easier way with improved IOP control and a reduced incidence of acute postoperative hypotony. So if I classify them as I've already said earlier, they are null valve, which basically require a temporary restriction for the initial 4 to 6 weeks by an internal and external ligation. And we have the different types, Beerwell, the Indian prototype of which is the Adi, and the Molteno, which is usually a double plate implant. Depending on the surface area, they have different sizes. The basic advantage of these is basically they have a larger surface area of the end plate, which acts as a reservoir. So a better or increased IOP lowering effects are there. And Adi is the low-cost version of the Beerwell implant. Disadvantages, obviously, there's a delayed time before actually it starts functioning. It's a larger size. There's a greater risk of diplopia because of the being placed under two different muscles, and a greater risk of hypotony if immediately we release the sutures or if we do not do that ligation. And more intensive follow-up is therefore required for these cases as compared to those for valved implants, where we have the prototype is the Ahmed valves, or the Crippen valves are the other types. Basically, again, they have silicon or the polypropylene is the basic material. The advantage is the immediate post-op lowering of the IOP can occur as soon as the surgery is done. And they are placed in between the recti, so they do not cause much of restriction of the muscles, and post-operative diplopia is not there. And obviously, the risk of immediate post-operative hypotony is also not there, because there's a regulated flow occurring because of the unidirectional valve functioning there. Although they have the disadvantage that there may be a high rate of bleb encapsulation leading to late fall in the late rise in the IOP. So now let's look at the indications of these. As I said, high IOP despite your maximal medical tolerated therapy and a prior failed glaucoma filtering surgery with the use of even antifibrotics. Or, as I said, cases of complicated and difficult glaucomas, which includes cases like aphakic glaucomas, those of neovascular glaucomas, those of refractory childhood glaucomas, those with uveitic glaucomas, or maybe after post-keratoplasties or post-vitrectomies. Other difficult cases of glaucoma are those with aniridias, those with Sturge-Weber syndromes, those with ICE syndromes, those we have excessive epithelial fibrosis, like in cases of post-chemical burns, post-cicatricial pemphigoid, all those cases. The cases where I would not prefer or go in for GDI would be eyes where there is severe scleral thinning, because I would not have a place to place these implants. There is an extensive fibrosis of conjunctiva where I will not be able to even create a space to have a reservoir for this end plate in cases of malignant glaucomas. The other two are not actually contraindications. Vitreous in AC, you have to be careful while doing your examination, and you will have to do an intravitrectomy so that the tube doesn't get blocked by it. And similarly, if there is a silicone oil, you'll have to change your place of implantation, which will be shifted from its preferred site of supratemporal to an infratemporal location in these cases, so that the silicone oil doesn't block the tube. So what are the preoperative considerations when we have to do such glaucoma implant surgery? A thorough clinical examination is important. On slit lamp, look for any neovascularizations. If neovascularization is there, it is always best to give an preoperative anti-VEGFs before you actually proceed with your surgeries. Look for vitreous in the AC, which I've already mentioned. You will need to do an intravitrectomy so that vitreous doesn't block the tube of your implant. Anterior chamber depth, you have to assess. Obviously, if there is anterior chamber depth, corneal touch, or AC is shallow, then obviously you will like to place the implant tube in the posterior chamber rather than in the anterior chamber. Gonioscopy, again, pass may interfere with that. Lens status you have to assess, because obviously in the aphakic eye, the pars plana approach, or in pseudophakic eye, in the sulcus placement of the tube is possible. Or if there is a dense cataract, you may even do a combined approach. So these are the cases where, again, you have to be more careful, because this will create problems while doing your surgeries with a deep set eye or a prominent nasal bridge. The choice of anesthesia obviously would be depending on the patient's systemic conditions. Ideally, a general anesthesia would be done in cases if there's comorbidities. Otherwise, you will have to give a block. These cases cannot be done under intracameral anesthesias. If you want an early IOP control and a long-term IOP control, so these are two things which we are looking at. So depending upon that, the choice of implant would be there. We would take up a valve implant if the IOP is very high and we not want an immediate IOP control. But if there is IOPs in late teens and we can do away with the small amount of continuation of medications 4 to 6 weeks, then we can go for the non-valve implants. And obviously, the studies have shown that the non-valve implants also work pretty better, except that the complications are lesser with the, I'll just finish here, with the valve implants. And again, for mild to moderate damage, obviously the valve implants are better. For advanced cases, non-valve implant will do. Location-wise, supratemporal is the best location. So you have to take care that there is a good sclera, there is no vitreous. The size, implant location, everything is dependent upon the type of IOP control which we want. Function of the foot plate, as I've already mentioned, it is placed in between the two muscles in cases of non-valve implants because of the larger plate size. Patient compliance is also to be taken into consideration. Surgeon's experience and comfort is another important factor which allows us to choose. Beginner may prefer a valve device. Cost is obviously the factor in our country, where obviously we are using a non-valve ADI device has come into frequent practice and frequent use. For vitrectomized eyes, use a valve device because the risk of hypotony is higher. Similar is the case with uveitic glaucomas. Same is the case with post-PK glaucomas, where we do not want the placement to be done in the pars plana tube has to be placed in the pars plana so as to avoid failure of the graft. And also in the cases of post-RD cases, obviously a larger implant will have more problems because we need larger area for dissection, and already is very, very cicatricial conjunctiva. It is already scarred conjunctiva. So on these cases, we prefer to go for a valve implants. Silicone oil filled, I've already discussed. For childhood, again, refractory glaucomas, long-term outcomes are not known, but yes, there are studies which say that in difficult and refractory cases, these will work. Past prevention I've already discussed. So these modifications I can skip, except for that we can even do for the non-valve implants, we can do a two-stage procedure. For if you want a initial IOP control, we can basically, without entering the eye, the first stage, and in the second stage, we enter the eye when the fibrotic capsule around the end plate has already been formed. So just to conclude in the end, GDDs are very successful in controlling IOPs in previously failed traps and refractory glaucomas. They're available in different sizes, materials, and designs. It is an individual characteristics of the patient in regards to his preoperative IOP, his optic nerve status, his desired long IOP control, and the surgeon's comfort and experience, which all decide which type of implant we have to choose. And numerous modification techniques have helped us in choosing these. And therefore, a careful preoperative screening and planning along with meticulous surgical technique can help in minimizing all the complications, which were thought to be very, very dangerous earlier when we were not doing the implant surgeries. Thank you.
Thank you, ma'am, for giving a broad overview of the general indications and considerations for your